that you can come up with a good management plan. Another way of conservative management would be reduction of pain. Splinting is the primary method of resting the wrist. Goal to rest. APL, EPB, therefore reduce the friction and the pain. Evidence, there are a limited or questionable quality evidence to support use of the splinting, but in here, we are commonly the first mode of treatment of DQ is resting with the splint on. So irrespective of evidence, or if you don't have much quality studies prove that splinting helps, here it's a practice that splinting helps in a first instance. No evidence of best type of splint or wearing regime. The best type of splint that we are making here is long thumb spica brace, long thumb spica splint. And the suggested splint type position would be forearm based one, of course. Wrist in a neutral to 20-degree extension. We prefer 20-degree extension because it's a resting position. And thumb comfortable radial abduction, approximately 30-degree. And MCP neutral to 20-degree flexion. And that include IP joint if pain on resisted extension. I want you to just carefully listen this particular sentence called include IP, interphalanx joint if pain on resisted extension. Naturally, what happens is in extensor pollicis brevis, it supplies to the MCP joint to extend. Okay, then why we are including the IP joint? IP joint extension is supplied by extensor pollicis longus, which is not in a first extensor component. Then what is the need of include the thumb? And that's where your clinical diagnosis, that's where your clinical justification and knowledge will come. Why should I include IP? I read about EPB and APL. Why should I include IP? Sometimes the reason is sometimes when there is a distal DQ, there could be a possibilities that ultrasound will pick up that DQ is not only in an extensor compartment, it could be a little bit distal to the first extensor compartment. That affects the EPL, extensor pollicis longus. In that condition, that you need to include IP joint as well, which means we call it as a full thumb spica, full long thumb spica splint that needs to be fabricated and should be wear for at least 6 to 8 weeks. I hope you guys are understanding with that. And, suggested splinting wear regime and progression 24 into 7, except a personal hygienic like a showering. I always tell my patient to keep the hand on the shower wall. Try not to check the painful maneuvering. When you are doing a Finkelstein test, ask the patient gently not to trial this test at home at any cost without the therapist. Okay, because the more they keep trying, what they're doing is they are flaring up. Okay, so just to gently advise them not to try this one up. The splint should be wearing at least for a 3 to 8 weeks time, and step down weaning process as patient symptoms improve. Decreasing wearing time as symptoms subside and progress to a more flexible off the shelf. When you know that at around 6 to 8 weeks time, if patient is recovering really good, 80% of symptoms gone, but they still have a 20% of the symptoms, they don't need to be in a rigid splint. The prefabrication splint or prefabrication brace can be considered that time in transition to full recovery of the DQ. Step up again as appropriate if patient experience flare-ups. So these are the off-the-shelf braces available in the pharmacy. But I only prescribe the splints at the end stage of the DQ, but preferably I would make a long thumb spica splint, custom made one, volar wrist and thumb MCP. Radial cutter, you can see the next slide. There are two types of custom made splinting patterns. One with the volar wrist thumb MCP immobilizing, and second with the radial cutter splint. So this is a splinting pattern that you can practice it, or if you have a thermoplastic at your clinics, this is a way start practicing it. This is your volar. This is my preferable way. I make all of my splint in this pattern, and sometimes because the reason for this one, if you look into the radial gutter brace versus the volar one, the volar one is my preference way because it covers the wrist completely, which means the wrist can resting it nicely, whereas here the wrist is covered partially, which means that the total wrist to be covered by the Velcro strap. Sometimes this is not enough to support the wrist. That's why I tend to go for the volar wrist and thumb MCP immobilization. But in your practice or in your clinical justification, if you have something else, more than happy to discuss with your staff and get going from there. Resting, splinting, and some research. 19 pregnant women that DQ is a self-limiting in pregnancy. Splinting provided some relief, whereas an injection provided complete relief of symptoms. Again, corticosteroid injection. Again, going back into how much pain they have it. If they have a mild pain, of course, the splinting will help. But in my way of preferable way of treating is I always believe in working along with the splint and corticosteroid injection together works much better than trialing it out to splinting for 6 weeks, then sending the patient to the doctor to go for a corticosteroid injection in a 2 different way. It's a lengthy process. It's a time-taking process. Whereas if the GP listens to you, I would always go ahead together. Getting the splint done, getting the cortisone injection done works much better. If you look into the next study, that 93 wrist that splints is of no additional benefits to the injection. Custom splintings alone was successful in 30%, and 45% of clients who eventually underwent surgery demonstrated an additional spectrum. You can see splinting research continued still. They say that, compared to, the NSAIDs compared to 35% and 25% in clinics and intermediate and moderate symptoms. And there are some other databases that found only the previous mentioned research supporting. Sometimes taping, specifically among the physiotherapists, they would like to trial kinesio taping. Would be a little bit pain relief. I tend to decline to practice taping because in the clinics that I would use the kinesio taping only for the feedbacking system for the patient at the second level of the treatment when they have like a mild symptoms. I would encourage to go for a taping, but preferably I don't practice taping because you have to remove the tape for a showering and put it back again, and if you are doing it in a wrong position, you are flaring it up. Taping preferably used by the physiotherapist, but in a hand therapy in Australia here, hand conditions are treated absolutely by occupational therapist. Physiotherapists, they can only treat from the shoulder conditions. Taping, milder cases may benefit from the taping instead of the splinting. I would again decline it as an occupational therapist. I wanted to go for the maximum support, maximum care of the wrist. In the taping mechanism, you can still allow the thumb to move it. So that's my opinion. The type of taping, you can use a thumb spica taping or a deload taping. And no evidence found specifically regarding the efficacy of a taping. Use the clinical justification. Physical agents, cryotherapy, which is icing, thermotherapy, heat pack, and for phronophoresis or iontophoresis, or we don't usually use that. Only in America they use that iontophoresis and phronophoresis, but in Australia, only this kind of physical agents we are only using it for a shoulder condition, but not DQ. They are DQ variants. They should be used over conjunction with the other discussed treatment modalities. So it's very important, like education, activity modification. But discontinued if the patient doesn't have any benefits from. Cryotherapy, as I said that initially, if it is an inflammatory condition, yes, of course, you can use the ice packs. But as I said that this DQ is a degenerative condition where you can't
see any swelling, which means that it's a chronic condition. It's repetitive strain. Yeah, it is a cumulative trauma. So I would facilitate more on a heat packs, heat therapy prior to cryotherapy. If they do any acute on chronic or flaring up and it swells up, then I would go for the cryotherapy. Otherwise, my preferable way of the initial treatment would go ahead with the heat packing. Again, electrotherapy modalities. There are other electrotherapy modalities are available, but again, in Australia, occupation therapists, very few occupation therapists are practicing electrotherapy. It is mainly for the physio, and they use their electro modalities. In Australia, only few hand therapy clinics, private hand therapy clinics, they use electrotherapy modalities. But you guys are not under any pressure to learn this one, because you guys are students. You have it's good to understand what are the other ways of treatment modalities. Laser, it's very popular these days, specifically physiological effects are spectacle, and there are studies proves that this is helping. In Australia, again, not many primary clinics are using acupuncture. This is one of the famous, very popular, that everybody's trying to do a dry needling and acupuncturing, because they want to have a differentiation in terms of treatment providing with the clients. I haven't done any acupuncture, so again, I don't know how this one works. Again, if the patients are from a work insurance, work cover will not approve this dry needling because there is no evidence. Enhancement of tendon healing and mobility. Again, massaging, of course, may be useful to improve circulation, improve nutrition to the tendons, and softening a hypertrophic tissue, specifically when there is an acute or chronic keeps on happening. That might be the tendon thickening, tendon sheath thickening, where the massage helps to reduce the thickening of the tissue, helps you to allow the mobility of the tendon nice and easily, and it may reduce the pain and improve the range of movement. Gliding and stretching, if you go for that, you can prevent or reduce adhesions and enhance the nutrition by synovial diffusions. When the length of the muscle tendon unit is increased, strain during the joint movements decreased. There are so many articles available in hand therapy journals and Quervain's textbooks. You can read about it and discuss about eccentric strengthening rather than pure gliding and stretching. I hope you guys are understanding what is eccentric strengthening. You probably studied at biomechanics what is isometrics, concentrics, eccentric. Now this is the time to recollect it. Any tendinitis, if you take it from the upper limb, we tend to follow eccentric strengthening exercises. So if you don't know anything about eccentric, and this is a time, go back, open up your textbooks, biomechanics, what is meant by eccentric and how to do eccentric strengthening of the muscle, which is very important to learn from the basics, because if you don't have a basics of eccentric, then you can't treat this condition effectively. Consider DQ to be a type of exogenous tendinitis and state that those, especially in the chronic state, need to be treated by removing the external forces. However, it seems generally accepted that total immobilization is rather detrimental to tendon health. Inflammations or swelling can cause adhesions, and tendon gliding exercises can reduce the swelling. Most research on tendon gliding is, however, conducted on finger flexor tendon post-injury or repair. Gliding and stretching. Suggested hand range of movement exercise for tendon glide. Tendon glide, six-pack exercises, the below the 5 exercises are considered as six-pack exercises, which is very, very important, facilitating the tendon. Wrist, on top of the wrist, flexion, extension, ulnar deviation, and radial deviation, and you got advice these exercises performed 5 to 10 repetition, 2 to 3 times in a day, and making sure it assess the pain and assess the aggravation as guided. Initially, avoid a combination of this movement as the Finkelstein as long as not too aggravating it. Gliding and stretching suggested for the nerve gliding, because sometimes when the nerve is specifically the DRSN not gliding very well, that is also giving us a pain. So allow the nerve gliding neurodynamic assessment positive, and you can, depending on the irritability of the symptoms, you can start doing the nerve gliding exercises as well. And some of the pictures that allows the sliders and tensioners start, you probably have the handout of all these gliding exercises in the clinics that the therapist or the staff is giving to the client for each session, what exercise they need to do practice at home as a home exercise program, making sure it these exercises to be included into that. Neural glidal immobilization, this will allow gliding the radial nerve from the brachial plexus, helps to allow the nerve to glide and stretch much better. Progressive strengthening, when performed in a regraded symptoms-free manner, it can accelerate tenocyte metabolism, speedy recovery, and prepare the patient to meet the physical demands of the daily activities. And progress strengthening tailored to individual needs, but not everyone got the same exercises. Everyone got a special individualized program that needs to be assessed and treated and reviewed regularly. Initially isometric to start with, for like a 5 to 6 seconds holding in a different position of the wrist, and then isotonic. In two types of isotonic is a concentric and a eccentric. Include eccentric loading is very, very important. And increase the movement into the stretching position slowly and gradually. When the pain subsides, you can start practicing that. Aim for endurance first, then a power as required. Again, you should know what is the difference between endurance along with the power. Exercise ideas, you may have a TheraTube at your clinics for practicing eccentric wrist radial deviation. And depending on the severity of the condition, that your therapist can facilitate this type of exercises for your patients. And these are another method of doing the eccentric loading with the red color TheraTube that will help you the patient's gliding and stretching. Rubber band stretching and towel wrinkling, all these exercises are very helpful in terms of treating this. Return to activity and modification. Encourage client to increase use as able, using pain as guide. Return to normal occupation based on the initial assessment on occupational requirements. In here, if it is work related and it has been proved, then the work cover insurance scheme will organize a ergonomic assessment of the work site by occupational therapist, and they will recommend. They will negotiate. They would liaise with the hand therapist for a better recommendation at office to implement it. Like for example, gel pad keyboards and gel pad mouse pads, height adjustable chairs, height adjustable desk, and the right height of the computer monitors, and regular breaks, regular stretch, exercise program at working. All these things back to return to activity and modifications. These are the things that below. Provide extra assistance advice to minimize provocative activities and repetitive forces. Regular breaks, maximum surface contact with the hand, use friction material on hand tools and utensils, widen grips, and wear handle straps to relax grip intermittently. Use electrically powered tools to replace manual tools. Spread the force over the 4 rather than one finger on trigger activity tools. So key holders, instead of like pinching the tiny, it could be like the keys that you guys are using for the igniting the scooters. That is also another way of putting a pressure on the first sensor compartment. You have key holders that can be helpful to maximum contact and trying to avoid the DQ. And the position of the computer typing, if you look into the computer keyboard, the bottom of the keyboard, you got a gel pad attached, or in the first picture on the left hand side of the top, you can have a gel pad keyboard available, or the gel pad also attached to the keyboard. That's called ergonomic keyboard. Helps to avoid ulnar deviation from there. And some other modified way of using the cutting board, cutting the wedges, cutting the apple and stuff, and the pen, position of the pen modifications. If you look into the bottom left hand, that's a modified pen that the patient can use it. And the another way of using it, putting the pen in between the index finger to middle finger to lessen up the pressure on the thumb. Corticosteroid. Success rates are 50 to 90% following 1 to 2 injection. Recommendations are maximum of 3 injections per year. Unsure why it works. Considering no inflammation in tendon present, because we talked about that it's as a degeneration, but how come this is improving by corticosteroid? Corticosteroid, you have 2 components in the corticosteroid: one, a painkiller, and second, anti-inflammatory. So possible effects, it could be softening the extensor retinaculum, which could increase the volume and reduce the friction. However, remember some signs of inflammation in the external retinaculum, so that the corticosteroid will help. Treatment post-injection, we need 7 days of resting after the corticosteroid injection, and possibly with the use of the splint. Both will be decided by the surgeon and based on the clinical presentation. Okay, the surgical intervention indicated after failed conservative management or symptoms too severe. As I said, that work cover scheme, we will wait for the 6 weeks to 8 weeks. Then if we know that it's not improving, I would directly go and talk to the surgeon instead of wasting time by putting a corticosteroid injection. I will discuss with the surgeon about how severe the symptoms, how long this has been dragging, and how much eagerness for the clients to return back to work, and then the pressure from the work. We all discuss about these things in the surgical meetings. Then the surgeon will take the patient on the board for a surgical release. And patient will come back to see me 2 days after the surgery for debulking the post-op dressing, and then start exercising, tendon gliding exercises, and stretching and gliding for the thumb will start working from there. Okay, there are 2 ways of surgical method. One, open DQ release, or endoscopic. Endoscopic is very rare that I have seen, but most of them are open DQ release, which is very successful. In terms of percentage, it is a 91% of success rate. Management after the surgery. Now you know that the inflammation is gone, the tendinitis is released. You have more confidence in terms of treating the patient now, because patient will say, will come up with a bit of swollen from the surgery, and you have stitches quite obviously on the first extensor compartment. And of course, you don't need to test the Finkelstein test that day, but you can work on, try to avoid ulnar deviation initially, and the thumb in base of the little finger position, but always the education towards keeping the wrist in a neutral or relatively extended position for a right management of that. And possibly splint for up to 2 weeks. See, I don't prescribe any splinting after the surgical procedure, but because the client got enough information already in their mind, what to do, what not to do, what gives them a flare up. So I would go through that educational point that try to avoid ulnar deviation, try to avoid a thumb in palm situation, keep the wrist in a neutral or extension rather than going for the splinting. Usual regimen regarding the swelling, pain, scar tissue, and tendon gliding exercise. Follow guidelines from the conservative management, but commence strengthening as appropriately in a 2 weeks time. Increase the functional activity as tolerated, and the patient can return to heavy lifting and forceful activity approximately 6 to 8 weeks time. So that's the surgical method, and references are here. Remember, you don't need to go through all these references, but simply you have just a basic textbooks available. Go through these conditions and check the, as I said, that do the provocative test among your friends, among your family members. Get used to this condition. Remember, definitely, if you guys, if you assess each other, you definitely, you may one or two come up with this kind of condition positive. Again, as I said, that you guys are using their hands almost all the time technologically, or using the smartphone and doing a project work, everything you guys are using, already exposed to the smartphones and computer. Okay, that's the end of the presentation. I'm shutting down. Okay, feel free to ask me a question.
Thank you, sir, for the wonderful and very informative presentation, sir. Students, you can ask your doubts regarding this recurrence disease. Students, do you have any doubts regarding recurrence disease and management? You can type it in the chat box. No. I think today, actually, today morning we had a sports day today. So
They're all
actually,
tired.
yeah. So
That's okay.
today
That's okay. As long as they're understanding that, and
that it
not.
is really, it's really very informative, sir. As you said, there is less awareness about the, I mean, hand rehabilitation, our role in hand rehabilitation. As you said, all the orthopedicians refer for the painkillers only. They don't look into the deep into the rehabilitation part of hand injuries actually. That was a very informative actually, and also as you said, preventive measures should be taken before the injury. As you said, prevention is better than cure, as we all know that. So the education regarding the ergonomics should be given to the all the, especially the IT professionals, and especially as you said, from the childhood itself, we should have a clear idea about the ergonomics so that we can prevent muscular skeletal injuries from the childhood itself. As we are using adding addict to the phones and the laptops from the childhood itself, sir. And it is really informative, and thank you so much, sir, for sparing your
Oh,
time
that's okay.
and sharing
No problem.
expertise knowledge
Because
regarding this condition.
yeah, we have this condition. At least I have at least 2 to 3 patients every day, either as a new patients or post-surgical patients or ongoing patient. Uh, Sometimes you feel very healthy, stressful when you are getting DQ patients, because you gotta do the same education to the client again and again. Um,
Yeah, yes,
it's a
sir.
bit.
Even I'm, I mean, I feel some pain when I'm using this laptop mainly for the PhD works. Right, as you said, I can use some that type of, I mean, gel you said. That I can use it when I use the laptop, sir. Thank you for the wonderful presentation,
Not a
sir.
problem.
Thank you for the
I think it's a
all.
good way in a clinically, if we, since we don't have many patients in India, how to do this examination, but you can make a demo, like assess the students each other in a clinical practice on top of the condition. Just make it as an interactive session. Generally, if we don't have any cases, make it as interactive sessions with our students, so that we all read about this condition in India, but if we never had any chances in terms of clinical practice, we tend to forget about it.
Yes, sir.
Here, subconsciously, that you have a plenty of cases pouring, because they have a much better understanding, better awareness from the local GPs, general physicians. They tend to go there, and the doctors, the patients next day, they come to your clinics. And you have a interaction, the loophole is happening all the time. But in India, if you see the doctor, They got no idea what they're treating for. They just give a
And we
maximum.
are ignoring symptoms and just having a painkillers to reduce those symptoms, but
That's
it will
it.
never end. We have to have this hand rehabilitation,
It's
and I think students will have information today. The insight would have gone for them that they should initially the occupational therapist role is very important for this kind of musculoskeletal disorders. So thank you so much,
and
sir.
then the
Waiting for
doctor
the
needs awareness. The doctor needs awareness, and the only way that we can, as an occupational therapy, create awareness not only among the patients, but we need to create awareness to the local doctors. Sending the students as a project work to the different local clinics, to the doctors, with a pamphlet of what kind of condition that we are treating, what is that condition mean for, sending the pamphlet to the doctors, handing over to those doctors by person, in person. They will start think about it, whether they have a clients in the based on the kind of condition. So it's easy to get the clients from the community.
Yes, sir. That is how actually we have created hand therapy center in our Savita College. As we all had a discussion with hand surgeons over here, sir. Actually, we are running a hand rehabilitation unit here in Savita College. But as you said, we have to go around Chennai and other Tamil Nadu or all over India. That OTIS should have give like a pamphlets, and we should tell them about our role, especially
Truly.
in hand rehabilitation. That will be nice. If we get so many cases referrals from those surgeons actually. So
Very good.
thank you so much.
Not a problem.
Yes, sir. And we're waiting for the other presentations as well. Yes, sir.
No
Nice
worries.
to-
Have a good weekend, guys. Thank you.
Yes, sir. Thank you, sir. Thank you.